Hi guys, I'd like to welcome you to this chat by myself, Seth O'Neill, on the etiology of tendinopathy in conjunction with the Physio Network. I'd like to thank the guys actually for inviting me to come and do this series of modules for yourself as well. This is the first of 4 modules looking at tendon management. It's basically looking at the tendon management of the lower limbs or the tendons. It's got applicable components to the upper limb, but the focus of my research is predominantly lower limb. So I'll tell you a little bit about myself, just so you know who I am. So I'm a university lecturer here at Leicester University. You're in our research room at this moment in time with some of the kit in the background. I work full-time now at the university. I have partly a research role and partly a teaching role still on the undergraduate physio course, but I still work as well in private practice for myself, and I see a mixed group of people, but quite a lot of complex tendon stuff within that. So I've got a good, hopefully, grasp of applying some of this research component to clinical practice, because that's always what it comes down to at the end of the day is, well, it's all well and good having these research answers, but does that actually match the patient in front of you, and does it change what you do on a day-to-day basis? Now, one of the things I feel quite strongly about is understanding disease etiology as being quite important for our clinical management. I think if we can comprehend what's happening to tendons during tendinopathy, we can understand where we might be able to intervene and change that sort of disease sort of process. And I think that understanding can help us shape our clinical interventions to do so. And the later modules will lead on from that. But this one's basically to give us all a good grasp, so we're all singing from the same hymn sheet and understand what tendinopathy is. And as part of the etiological process, risk factors are critical. And really understanding how a risk factor influences the disease itself is pretty crucial to actually getting a good grasp on how to manage our patients. So let's get cracking. So one of the big things when we consider tendinopathy is really understanding what size the problem is within the population. And this fantastic study from the Dutch group led by Elbers at the time showed that gluteal tendinopathy is far more common than the other tendinopathies are. If you're not seeing a lot of gluteal tendinopathy within your clinical practice, maybe you need to consider whether you're actually misdiagnosing them as hip or other sort of gluteal syndromes that might exist. And I think that's something that we've all fallen foul of in the past as well. And looking at some of the testing processes that you might use for gluteal tendinopathy from people like Alison Grimaldi would be pretty useful for you. Plantar fasciopathy is on there because it still has the same sort of process as a tendinopathy, even if it's a fasciopathy, and I think it should be considered as one and the same. And the reason we've got tib-post disorders in red on this particular graph is because that comes from a different data set. There's very few studies that have looked at tib-post prevalence or incidence rates, and this data set came from a UK population of 40-year-old women. So it's probably a bit lower than that in the general population, but it's a big enough issue. Now, if we move on then to actually look at sort of how this links to other conditions, based on the Dutch data, tendinopathy in the lower limb is actually more common than osteoarthritis in the lower limb, with a sort of nearly 12 in 1,000 people affected versus 8 in 1,000 people affected. That's a pretty huge difference really for me when it comes down to numbers and on the population scale. But this isn't something that our undergraduates are learning. It's often something our physio colleagues haven't learned as well, and it doesn't always reflect what you see in clinical practice. Now, some of that's because these things don't get filtered through to come and see therapists, and some of it may be that it gets misdiagnosed as other aspects as well. So we need to consider our diagnostic accuracy when we're looking at diagnosing tendinopathies. And within that sort of wide population as a whole, we need to consider specific subgroups. So when it comes to the Achilles, which is where the majority of my work is completed, what we actually find is that Achilles tendinopathy is far more common in certain groups, particularly endurance runners. And in UK epidemiology work that I've completed as part of my PhD, the lifetime prevalence for Achilles problems was 57% of that group, with a point prevalence, so those people at that one time period that we looked at, of 44%. Now, that is huge. That suggests a very large problem, particularly if you look at the numbers that run within the UK doing endurance tasks. It's somewhere in the region of getting on for 10 million people that regularly participate in running-based activities. So it really could be a large problem that's actually been undiagnosed because people don't necessarily always go into the NHS to be seen for this. It often impacts older athletic people, but also older people who are sedentary get Achilles-based problems as well. And I think that seems to be true of all tendinopathies. There seems to be two cohorts. It's an active aging group, so the people in the 30s and 40s who get overuse tendinopathies. But then there's another population who are more sedentary and older, so 60 or 70-year-olds, that developed different tendinopathies. Those tendinopathies will normally be either Achilles or gluteal tendinopathies. So I think we need to consider sort of two populations, and there's also another population split where we have active people on the one hand and sedentary people on the other. And we'll come to why that's the case, because sometimes people struggle to rationalise why we can get these two groups. Now, the important thing to also discuss based on the current data out there is there are different sites for developing tendinopathy. So all tendinopathies, really except maybe the tib post and the Achilles, are insertional tendinopathies. The Achilles can develop a mid-portion problems, okay, and those mid-portion problems are in this zone around about 2 to 6 centimeters from the actual insertion into the calcaneum. So that, in our study, accounts for around about 70% of the population reporting symptoms. Insertional tendinopathy is not normally around the actual true insertion into the calcaneum, but where the arrow is showing you at the moment. It's around this area where there is a bony cam, this superior aspect of the calcaneum here, and the deep retrocalcaneal bursa. This is the superficial bursa just here. Well, this deep bursa that we've just shown you gets squashed against the calcaneum during dorsiflex positions, and with insertional tendinopathies we can get changes in the bursa, the bone, or the tendon, or combinations of all of those three things. And I'll show you a little video a bit later to show you that, so you can sort of see that happening as well. Now, they're the common splits, but you'll notice that doesn't make 100% of the population. So what's the other sort of group within it? Well, the other group in our data is actually combinations of those two entities. And I think that's where we need to be considering missed points, is that does one lead to the other? Is it the chicken and the egg, or are they two different entities and it just happens to be that the risk factors are the same and the etiologies are the same? I think that's something we can comprehend as we go down through the modules. Now, the other important bit to draw to your attention on this particular slide is the mechanism of onset that we have highlighted down here. Now, within that epidemiology work we did on runners, there was different modes of onset reported by the participants. Some people reported that they had a sudden onset, this blue cohort here. So that's a sudden onset during an activity. The green, on the other hand, over here is a gradual insidious onset. They weren't really sure what had triggered it. It had come on gradually. And the red component is the day after training. Now, in my mind, if it comes on suddenly during an activity, whether that is a sudden sharp pain or a gradual build-up of an achy, crampy sensation within a tendon, I think that may be considered the possibility for collagen tearing. Okay, and I think they could be a subgroup within the population. So clinically, you need to tease out these elements, and within your analysis in your SOAP notes, you need to be recording what the mode of onset was, because it's my clinical experience at the moment, and we have some ongoing work with the 40th Clinic in London looking at this, that this population may represent collagen tearing, and they may need different management. Within our running group that we look at for Achilles problems, the patients report certain factors as being the trigger for their onset. And this was related to the epidemiology work I showed you just now as well. Overload comes out as the most common factor that patients or subjects are suggesting is the trigger for their disorder. And that's without me putting words into their mouth. That is asking them what they thought led to it in their own sort of right. So it's essentially running and increasing training within that running or running harder, which all comes under the overload umbrella. Now, as I mentioned, we have a split in the populations. We have the active group, and in the Dutch population data from Elbers and also some of de Jong's work, they've only shown 35% of that sort of Achilles group actually had sports involved. Now, one of the things you need to consider is, was that actually assessed for via the GPs that saw these patients? Did they look at sporting history? Did they ask about it, and did they seek that? It may be that they've missed it, so it may be higher. It's certainly higher in the groups I predominantly see, but we all sit in our little sort of towers of work where we only see specific populations based on our current work. So I certainly see a lot of sedentary ones as well. But is the split that particular level, nearly a 35-65? I don't know. But sedentary groups definitely develop tendinopathy. Now, why they develop it is something we'll come to. There's been a big argument over the last 40 years, probably, even a bit longer. When I trained at university, tendon disorders were taught as tendinitis, okay? And when my students have been taught, they still get taught it as a tendinitis sometimes. But clinically and in a lot of the research, it's been suggested it's primarily degenerative. And the first papers on this were in the mid-70s by Purdue, suggesting degenerative changes, and it's a tendinosis, not a tendinitis. However, that debate's been sparked again in the last sort of 5 years or so, where now researchers are showing inflammatory components. And those inflammatory components are cells that are immunoactive. So that doesn't necessarily show true inflammation, it just shows immune active cells within the tissue that are actively doing something and being engaged. But there are certainly inflammatory chemicals that seem to be linked, but these chemicals are on a low-grade inflammatory messaging molecules to trigger adaptation in the tissue, much like we get if we went for a run and our muscles afterwards would release chemical messages to each other to trigger adaptation within them, and those are very low-grade inflammatory chemicals. So from a research perspective, I think we can say yes, inflammation exists. From a clinical perspective, is it useful to engage in that discussion with the patient? I think that's something you probably have to take on a patient-by-patient basis, but in my mind, inflammation to a patient normally means I need to rest this. And I would always ask your patients when you've got them, what do you think's wrong with your tendon? Is it an inflammatory condition? Is it sort of degenerative? What's going on with it? And see what they say, and then follow up with a question of what they understand about that. Now, as I said, the inflammation isn't going to go away in terms of the research on it at the moment. Whether it's ever going to lead to a targeted intervention that will target some aspect of this complex reaction, I don't know. But one of the key things I think as a clinician we can take away is it's a failed healing response. It's a chronic inflammatory fibrosis of the tissue that leads to failed healing. And this is something I think matches no matter which of the sort of two camps you fall into. And as I said, it's really a combination of two. It's not at one extreme, degeneration or inflammation. It's this reaction, and probably at different stages there's different sort of switches into more inflammation or less. But essentially, this graph tells us exactly what goes on. And this is from British Journal of Sports Med paper by Dakin, that if you overload a tendon cell by giving it too much stress, you move it from the healthy component into an injured state where the cell changes its shape and it becomes much more metabolically active, excreting chemicals that make the tissue change more and more and more. This cell they term as a primed cell that is overactive. It is panicking when you stimulate it. And that stimulus normally comes through from exercise or activity. And those exercise or activity levels can be very minimal sometimes when you've got a primed cell. So these are the people that have flared their tendon up, then they do something very small like have a short walk or spend the day on their feet, and their tendon really gets sore the next day and they're struggling. And that's part of this process. However, it's not just about cells changing. There's also some good evidence that there's changes in glucosaminolycan content, commonly referred to as GAG content within the tendon. And actually by Alex Scott's group with ATIA, they've been able to show that the GAG content, as stained for sort of down here, the sort of blue and the green staining, is actually associated with pain. So what we've got is a tissue histology section up here. This tissue's healthy, it's nice and linear, looks lovely. Now, as we go down, the tissue starts to have more cells in these little sort of end pieces here where you've actually got the nucleus of the cell shown. So the tissue gradually gets more and more of that. And that's something we see in tendinopathy. And what you've also got reported here is the VISA scores. So this is VISA P because it was patellar tendon biopsies that were used. For hundreds normal, and as you get worse, score of 13 being very bad, you can see the structure looks worse. And that structural change and the scores correspond, as you can clearly see. And also what corresponds with that structural change is the GAG content. Now, interestingly, there are some studies that have shown the GAG content, or GAGs I should say, sensitize neural tissue. They make the neural tissue in animal studies where it's been looked at become mechanically sensitive. And we know in tendinopathy that in these disordered areas of tendon that there are more nerves than there should be. There's a neural ingrowth and a vascular ingrowth. And it may be that these GAG sort of changes actually cause sensitivity of that neural tissue. And GAGs are excreted by the tendon cells. Okay, so those cells are part of what drives all of this change. And GAGs are a hydrophilic molecule. They love water, so they suck fluid in, and that makes your tendon swell up. And that's why we see big, fat, swollen tendons. Not inflammatory exudate, but actually water content changes. Okay, now, there's a multitude of tendon sort of theories that have been published suggesting that there's stress on the tissue that leads to changes in the tissue, which eventually leads to something that we would term as tendinopathy. Now, there's the iceberg sort of hypothesis. There's various neural hypotheses and blood vessel hypotheses and compressive hypotheses, but they all have the same components within them. They all suggest that stress on normal tissue within physiological sort of limits can normally lead to tissue adaptation that becomes more robust and more resilient, and the body copes, hence getting bigger muscles. If you go to the gym, for instance, the tendon will adapt in the same way. However, if you overload the tissue, it's too much stress too soon, you cause degradation that involves an inflammatory response, and that sets up tissue adaptation that is basically the process of tendinopathy. Now, all of these models that have been published, they all show those same things. They have at the heart of them that same component, that the body gets stressed. Here we can see in the Cook and Purdon model, the body gets stressed, the tendon, you could cross this out and you could actually just call it tissue. And this is exactly what I do with our students for any overload condition like stress fractures or sort of osteoarthritis. You take a normal bone, you load it appropriately, the bone adapts and becomes more resilient. Happy days. The bone gets overloaded, it degrades and eventually fractures through. Stress fracture. It's a degradation with an inflammatory component. Tendons are exactly the same. In Cook and Purdham's model, they term it reactive tendinopathy, and then goes through to disrepair and finally degenerative, and they think it's non-reversible at that stage. That's something I think that's up for debate at the moment, but certainly it offers a model to consider clinically, and it's probably the most widely accepted model that's in clinical use. And obviously the more recent Dakin models come out as well. Now, all of these etiological models, as I said, they all show the same processes being involved. They all show that the tendon cell population increases. We have more cells that are more metabolically active, and these cells are normally look like they're immature. So instead of being an elongated cell, as you saw in the Dakin model, they now become more rounded. And these cells have a higher rate of programmed cell death, which is what apoptosis is. And there's more immunoactive cells as well, suggesting tissue repair and loss are raised quite significantly. Tendinopathic tissue has the metabolism about 6 times that of normal tendon tissue. This activity leads to collagen degradation. Okay. There's more immature collagen bundles rather than the big mature fibrils that we'll see. And the ground substance changes with the GAG content we've mentioned and proteoglycans being another sort of lubricant molecule. There's more water there, and there's a variety of substances that are known to make tissue more sensitive as well, so increasing pain. Substance P, glutamate, lactate, and a couple of other things as well that are suggested, but there's evidence for those, alongside these near vessels that come into the tissue. And that is what happens in tendinopathy. Any tendon we look at in the body seems to undergo this same process. Okay. What that looks like if we use ultrasound imaging of a normal tendon at the top is a linear, lovely tendon, and it looks in cross-section, if we chop through it in the transverse plane, looks quite nice and small. At the bottom you can see a typical tendinopathic tendon that is enlarged with hyper and hypoechoic areas, changes in the tissue. Now those changes matter. So in a normal tissue, this one on the left, both sections, if we chop through it and look at the sort of tissue from end on, like looking at a pack of spaghetti before cooking, all the fibres are the same size. It's lovely and healthy. This is essentially rope-like collagen, healthy big fibres of collagen. If you look at it from outside the pack of spaghetti, you'll see the fibres are all lined up. They're lovely and linear, nice and thick. That's what we have in normal tissue. In diseased tissue, what we have are much smaller fibres, these ones here, versus the big, healthy, normal fibre. And you'll see that the tissue is broken down. There's all these small ones. Well, those zones where you've got the small fibres are essentially what you'd see as a hypoechoic lesion on an ultrasound scan. That's the degraded area of tissue. And if you look at the pack of spaghetti from end on, where you've got these lovely fibres, what you essentially have, according to the consultants that describe this in surgery, is mush, which is what you're seeing here. The tissue is degraded. Now, this comes from an animal study that looked at exercise being applied to tissue, or tissue being stress shielded in this instance. So they severed the muscle and then observed what happens to the tendon. So essentially what we know is this change in the tissue comes about through rest, in the case of stress shielding, or overload to the tissue. Both models have been done in animals to reproduce this same change. Now, that's showing us that wear or repair are a key part of actual tendinopathy. That is rest, or sort of rest, or the stress on the tissue triggers an adaptation. And when we've done a Delphi study of world experts and looked at risk factors, they seem to fall into these two camps. They either stimulate the stress on the tissue or the repair rate of the tissue. And it's important to go into each of these factors in greater detail at some stage to comprehend how and why they may increase wear and how and why they may influence the body's repairability. But we'll just cover a few of them now. So genetic predisposition just in the repair stage down here. Genetic predisposition is linked to certain genes, collagen 5-1A gene and another MMP3 gene. They code for collagen production or degradation of the matrix. And they're associated with tendinopathy because they influence our wear and repair of the tissue. We have adipose tissue, increasing inflammatory cytokines. That influences the body's reparative processes. We have diabetes that influences advanced glycation end products, AGEs, and they make the tissue stiffer and less able to adapt to a stimulus. Previous tendinopathy is known to alter the body's ability to sort of respond to load in very short-term studies looking at the response after a day or so from loading. So these things influence the body's repair processes, normally to the negative. And then obviously if we exercise, we increase the stress on the tissue. I often use a calculation saying, well, walking's 4 times body weight through the Achilles tendon, for instance. Running is 6 times body weight through the Achilles tendon. Do a step calculation for the distance the person covers, you suddenly start to understand where the stress is coming from. And there's good data to suggest that that definitely leads to some increased synthesis and some increased degradation of the tissue, and that's where we get this wear-repair balance from. That process, as we said, involves some low-grade inflammatory chemical messaging molecules that help to sort of stimulate body adaptation. Sometimes it's too much, sometimes it's too little. Now, this is a graph that helps prove that wear-repair balance. So this is, as everyone often says when they use it now, the most used graph in tendinopathy. It's from Magnusson, Kijar and Lamberg, first published in 2010 in one of their papers. And we've got synthesis at the top, this is the green. Down at the bottom we have the red, which is degradation of tissue. And what they did in this wonderful study was they inserted needles into the paratenon around the Achilles tendon, made people exercise at this time point, and then looked at how their levels of chemicals that link to collagen synthesis or degradation changed after the exercise. And the net effect is this line. So essentially, there was less, according to their data, less Achilles sort of structure, less collagen for around about 36 hours, and then there's more. That's this crossover point. And that's important. So it shows us there's a degradation that's greater than synthesis. But it's important to comprehend how much exercise was used. This was 30 kilometers running. So for those of you that are UK-based or work in miles, like in America, this is 20 miles basically. A long run, but in trained athletes, and this is their typical longest run in their training week. The same effect may be observed with people doing their most exercise for a given week, but we don't have data to show that, okay, because those studies haven't been done. This study has been replicated for the patellar tendon with the kicking exercise and shows the same type of response as well. People use this graph to say, well, we shouldn't exercise within 24 hours. It is not what it tells us. It tells us that after doing a very high level of loading, we may need some additional recovery, but that training could be done within 24 hours, but it needs to be low. It needs to ensure that what we don't do is degrade them even further and take them before they're recovered and degrade further and eventually lead to tissue degradation. Equally, if we rest, the tissue would degrade. It would drop and have less collagen at the start and be somewhere down here. And this is all part of what we have to consider with tendinopathy. Some people may have slower recovery, as we've just drawn on now, due to poor diets, poor sleep, other risk factors that link to the reparative process. They all need to be considered with the person that's in front of you. And sedentary people, as we've already sort of alluded to, are probably starting with less collagen in the first place and probably don't have such a big primed reaction to exercise because they're not used to it. The cells are essentially switched off. The genes are not turned on. The fire hasn't been stoked. So we have to bear that in mind. Now that wear and repair process has been studied a little bit using sort of less invasive procedures where sort of Sam Rosengarten with Jill Cook's group, they used UTC, so ultrasound tissue characterization, to look at tendons of Aussie Rules football players pre and post game. 15 approximately kilometres covered in a game by an Aussie Rules footballer showed a transient alteration in the tissue structure that perhaps matches what has been observed in Magnussen's, Lambar's and Kijar's work. They also showed a similar response with Sean Docking leading this paper in racehorses in Australia as well, where there's a transient degradation in the tissue that then returned to normal at around about 5 days. So it seems to be the case that this happens. We've looked at this with rugby union and some running events and shown a similar response to occur as well. So it seems to be accurate with what's happening, and the tendon undergoes these transient adaptations. Now that tells us it's active. It's not an inert structure. It's a very, very active structure that responds to loading, and that's important. In animal studies, when they've looked at what type of loading is relevant, what they've done is looked at, and I hate graphs, so I do apologise for a bad graph, but what they've looked at in this study was tensile load here. They've looked at compressive load there. And then the white graph is the combination of tension on the tendon and squashing at the same time. And this was in a rotator cuff in a rat model. What you'll notice is the cross-sectional area from baseline here goes up when you apply tension, compression, or the combination. You'll notice that the combination increases the cross-sectional area of the tissue most. Okay, that was significant as identified by these little asterisks. Importantly, whilst the cross-sectional area has gone up and people say the tissue is therefore stronger, the max stress that the tissue would tolerate dropped. So tissues increased in size, but its resiliency to stress has dropped. Max stress being the stress it would take to cause tissue failure, tissue rupture. And modulus is another measurement that I won't bore you with, looking at the material properties of tendon tissue as well. And that drops most when we use this combination of compressive and tensile loads. There's your reference for it if you want to have a little look of it. It's an interesting paper, so do have a read. Now, that combination occurs in all tendons when we look at them undergoing normal activity. What we normally have, as you can see sort of here, is a little bursa that's just moving, just in this zone. That bursa's moving, as in this instance, that we dorsiflex the foot. So the person's lying prone on an examination couch. Their heel is over the end of the bed, and their foot's being dorsiflexed whilst the probe's on the Achilles. The Achilles is this top section. Well, I can draw on it, lovely. The Achilles is that top section just there that's moving. If we just play it again for you, and you'll see the bursa just here moves. But most importantly, you can see that the calcaneum migrates into the Achilles tendon, hence having a bursa there, hence the bursa moving as it does so. And what happens as far as we theorise in insertional tendinopathies at the moment is this combination of compressive load and tensile pull can, in certain situations, overload the body's ability to recover and repair after training. It doesn't mean compression is a bad thing. It is a normal thing, and we need to rehab our people to withstand it. But it explains why we get problems there. It's the bony cam. And the bone can respond, the bursa can respond, or your tendon can respond, or combinations of all three. And that is essentially what any insertional tendinopathy is. Think of the shoulder. If this was the acromion here, this is your supraspinatus as it attaches. We always expected to see tendinopathy in this area. What most studies then started showing was you saw this area as the lesion of tendinopathy or a cuff tear. Well, that makes sense when we consider what's happening with compression from the undersurface and why the tissue would degrade. So compression is important, and I must take a moment to thank Peter Gettins for that video. If you don't know him, follow him on Twitter. He's an excellent clinician, ultrasonographer, and tendon geek as well. Okay. So in summary about etiology, tendinopathy is a big problem. It affects the gluteal tendons more commonly than something like the Achilles. Within tendinopathy, we see large changes to the cell populations, the numbers, their activity, and also the processes that are being involved. This is brought about by tissue stress, tissue load, that eventually leads to disorganization of the tissue if that stress is perpetuated for a long enough time period. The changes are quite profound in ground substance, cells, the collagen itself, and the vascular components within it. That really comes down to influencing the wear and repair on the tissue. In later modules, I'll cover what that wear is and those risk factors related to active and inactive people in a little bit more detail. But essentially, they're our key problems. Now, to be successful in our rehabilitation, we have to work out where we can intervene with improving the repair rates or reducing the stress in the short term. And then we need to stimulate normal cell activity off, because at the end of the day, our target needs to be targeting the things that went wrong. Well, if we change the cell activity, we'll eventually change the tissue. Equally, I must point out that my slant of clinical care is probably not so much about the tendon per se, it's more about looking at neuromuscular activities, because if we get the muscles working properly, the muscles will shock absorb and protect the tendon, and eventually your tendon remodels and repairs. Thanks for listening, and I hope you're looking forward to the next module as much as I am. Cheers, guys.
No problem.